So the first lecture is by Prof.Bancha. So Bancha is very famous as a shoulder surgeon, especially during shoulder session with a special interest in knee. So you're going to tell us about superior capsular reconstruction using a denture facial data and with a special triple lumens techniques. So after the lecture, then we follow our open discussions. All right, thank you.
Thank you. Good morning, Dr. Bancha from Thailand. So I'm talking about the superior capsular reconstruction using tensor fascial data, the triple lumen technique. Thank you, the ConMed Linvatec, for the invitation today. I'm a good fan of class meeting, never miss, only I think 1 or 2 times. Yeah, so this is a ConMed team, and I met my professor, Yang Kali, and Dr. Park, Sangjin, and Ni guys, yeah. So he's so happy to see me, Dr. Sangjin. And also see the next ex-fellow from Indonesia, Philippines, yeah. And this is our Thai team, yeah. We always support the class meeting. So I learned from Telu Mihada. It was in 2016. Yeah, I came with Chanakan and Dinchon to visit him before we going to Osaka. So I think that is very useful in my practice, the SCR. So from the literature, you found that the outcome, range of motion, and the score getting better after the surgery, and also the pseudo-paralysis can reverse 93% in his study. But the European or American, sometimes they don't believe in this, and I'm not sure why, but I think in our Asian SCR, the outcome is pretty good comparing to the Western side. Okay? And also the recovery time, sometimes it takes longer if the patient have pseudo-paralysis. Sometimes it's up to 8 months. So comparing SCR to reverse, if you have a good healing of SCR, the outcome is comparable to the reverse shoulder arthroplasty. Also, if you compare to LD transfer, the SCR is better. Okay? If you compare to lower trapezius transfer, they said the lower trapezius a bit better comparing to SCR. But if you combine SCR and lower trapezius, the outcome is good, very good, comparing to SCR or lower trapezius alone. Yeah. These are the indications. We do it in the revision cup repair, post-row superior rotator cuff tear, but the patient should have good cartilage, Hamada 1 or 2, okay? And the key point is that you should have good subscapularis or repairable subscapularis. If the patient have bad cartilage, okay, Hamada more than 3, or irreparable subscap, this is not a good candidate to do the SCR, okay? So this is the key. Yeah, if you want to do good outcome SCR, first you need to have very thick graft. It should be thick like 8 or more. Okay, and autologous tissue is better than dermal patch or allograft because of the healing potential of autograft is better. I need side-to-side repair. When you repair the cuff like this, you need to have side-to-side also. Okay, this side-to-side repair will have better healing. Yeah, and also you need knot tying. Knotless is not good because the cuff is thick. If you do knotless, you don't have enough pressure to put the cuff on the footprint. Yeah, so these are the key factors that you have good outcome in SCR. So the failure is vary from 5 to 70%. It depends on the literatures. So my SCR technique, I start with the decubitus when I learned from Mihata, okay? But I come back, I cannot do that because I'm the big chair, like Professor Yongeli. I have my back pain and AC joint pain. So I stopped doing decubitus, I do the big chair position. So first I start using the same position, same side, but 2 teams, they jamming. So I decide to do separate. I have it opposite side and operate on this side. Okay, so this is easier. You can separate 2 teams. Okay, we start with no syringe technique. Okay, and then we go to double syringe, and now we do triple lumen portal. So the good thing is that you will have no problem with the suture management. 24 suture, right? 24 suture. So it's a bit confusing when you do the suture management. Yeah. So this is the key. When I get in, this is my graph. This is a diagram. When you pass in, I will repair, put the suture in the graph first like this, and then push into the joint. Okay. Then this one will go to the infraspinatus, and then you can do the side-to-side repair like this. When you get in, if you do side-to-side, the graft will be spread. That is a key point. You need to spread the graft first, and then you tie the knot. Okay. I will have each hole. We have 2 sutures. Okay. So you have 1, 2, 2, 2, 2, 2, 1. Okay. Last time I told you 1, 2, 3, 3, 2, 1. You remember? That's different. That last year, but this year 1, 2, 2, 2, 2, 1. Okay. So this one, when you tie it, you spread the graft, and then you after that, the key point is that you need to repair the loaded calf to cover your graft. So your graft will be like sandwich. The graft will be between the bone and the stump of the loaded calf. So the healing of the medial side will be better. Okay. And then after you make a knot tying, you can do the suture bridge like this. Okay. So I recommend to do knot tying, because if you did not make a knot, the pressure is not enough. Okay, the cup is very thick, 8 millimeters. Okay, let's go to the case. This is the first one. This is my first SCR 2016 when I come back. So he had the big size supraspinatus and infraspinatus tear. Okay, so we start with the microfracture on the medial side. Okay, to make a good, and then we put the Y knot. Okay, one on this side and one in the back. Okay, so I prefer to use a triple load. Yeah. So now there's 12 suture. You start with side to side first. Okay, you pat the suture. This is the suture that you make side to side. So make it like rectangular. Okay, like this way, and then one in the front. But Mihata don't do this. He not making the anterior repair. He just makes side to side in the back. Yeah. But I think I'm very happy to make it like front side to side for front and back. Okay, and then you make the graft, yeah, like this. So your graft should be thick enough. You see, this is the decubitus position. Okay, we pull this in, and then we repair it. First we spread the graft. Yeah, using switching stick very helpful. Okay, and then you tie the knot one by one. I start with side to side first, in the front and in the back. Okay, like that. Okay, and then we tie the knot on the medial side. Then we put the anchor on the lateral side. Okay. Previously, this is the old technique. I pat the suture later, but now I know that I pat the suture outside, and when push the cup in, it's easier. Okay. And then we make a suture bridge, yeah, for the lateral row, like that. Okay. That is the intra finding, and you see that the outcome after 1 year, the outcome MRI is pretty good, and the patient have very good function. Okay. So the power of external rotation is better, and also the joint test is also better. Yeah, we can restore. Okay, and then we switch to the second generation, my double lumen. Yeah, this is a double lumen technique. The patient have weakness of supra infraspinatus. So even the patient infraspinatus, I will make a bigger SCR. Okay, for myself, I don't like to do lower trapezius transfer. I do big SCR to cover both supra and infraspinatus. Okay, this is have the supra and infraspinatus. We make a bigger graft. Okay, harvesting, and then the same, right? We make anchor on the glenoid. Okay, triple loaded. Okay, and then we make side to side first, as I show you in the diagram. Okay, like this, front and back. Okay. We make it on the middle row and lateral row. Okay, like this. So you will have this picture. Okay, and after that, we pat the suture. This is side to side. And use your finger to make sure if your middle finger can get in, your graft can get in. I use my middle finger, it is biggest. Okay, don't laugh. Middle finger is biggest, right? Not little finger. Yeah, so then we pat the graft in, and make first side to side, yeah. Okay, and the key is that the suture I will pass it underneath the rest of the supraspinatus stump, yeah. Okay, and then we make a suture bridge on the lateral, like that. Okay. So finally, and then, okay, and then you make sure that you have the nice suture configurations. And this is an MRI 1 year after surgery. Okay, the patient have good motion, and also he has the good strength supraspinatus, also the infraspinatus. Okay, you see, infra is come back. Okay, so it's very reliable. This is the patient that have done the triple lumen technique. He has atrophic change of the infraspinatus and supraspinatus. Okay, so we make a big SCR. You see, proximal migration, supra, and also the upper part of infra is gone. Okay, so this is the way to do that. You need totally 4 syringe. First, you use the 10 cc syringe, and this is the spinal needle rubber sleeve. You just cut it. Okay, so you put this into your syringe like that. So you have 3 syringes inside. So when you get in, and you can manage your suture. Okay, this one is for the glenoid suture, and this 2 is for the humeral head suture. Okay, that will not mix up. Yeah. So after harvesting the graft, then you can put the suture in like this. Okay, and that is the rest of the supraspinatus. I will lift this up. Okay, when I put my graft in, my graft will be underneath the stump of the supraspinatus. Okay, like this. Yeah. So we pass out the suture this way, and can push this into the navicular portal. This is coming from navicular portal. Okay, put the graft in. Okay, I prefer to pull in, not push in. Mihata, he like to push in, but I use navicular to pull. So it's one direction, it's easier. Okay, once you get in, you use the switching stick, push the graft in, make a glenoid suture. Okay, and then make side to side and suture bridge. Okay, so I tie all the knot. Yeah, I never have type 2 tear in SCR because the graft is very thick. But it's different from rotator cuff. In rotator cuff, I will not tie too much knot on the rotator cuff. But for SCR, I think if you tie the knot, you would have better contact healing. Yeah. So yes, and then you have the this is big coverage, the infraspinatus to the rotator interval. Okay, and this is the post-op. Yeah, very thick graft. You see, HI is restored. Okay, and we can restore the external rotation, also the abduction. Yeah, the strength is coming back. Yeah. So in conclusion, the SCR, I think it's very reliable in our hand, and the outcome is good for the massive irreparable posterior superior cuff tear. So using the triple lumen technique, it's straightforward and make the surgery much easier. Okay, thank you so much. And next year, we'd like to invite you to Thailand. We have the meeting in Hua Hin in July and in October. Okay, thank you so much.
Thank you, Professor Bancha.